Everybody, Dr. Rob Sylvan here, Proven Health Alternatives. I'm here with orthopedic surgeon turned osteoporosis superstar guru, Dr. Doug. Doug, pleasure to have you here.
Thanks, Rob. Happy to be here.
Yeah, let's talk a little bit about osteoporosis. Let set the terrain for you. Osteoporosis, a disease in which the bones become fragile and more likely to fracture. It is the most common type of bone disease. Osteoporosis increases the risk of breaking a bone. More than 50 million people in the US live with osteoporosis, both men and women. Experts estimate that about half of all women have it, and 1 in 4 males over 50 have osteoporosis. So everybody knows bone is a living tissue, existing bones constantly being replaced by new bone. And that is where the problem lies, where the new bone and the old bone kind of meet. What is osteoporosis to you, my good friend?
Yeah, actually, I like that as a definition. So I would look at it in a similar way, which is that osteoporosis is really an imbalance of bone metabolism. So you kind of just said it. New bones always being formed, old bones always being broken down. I kind of liken it to like a highway. You have to take out the old highway before you build up a new highway. Everybody's seen that happen, right? It takes, 20 years for whatever reason. And bone is similar. So it's always being broken down, but it's at different rates. Bone is always being built up, but at different rates. So osteoporosis then is the sum of too much breakdown, not enough buildup over some period of time. So that's osteoporosis. Now, people have heard of it because of the T-score, because of the DEXA. I'm sure we'll talk about imaging, but that's all just diagnostic criteria for other purposes. The definition really is an imbalance of bone metabolism.
So it comes back to the theory about the body, and you said you had a chiropractic family background of being in homeostasis. So we were talking essentially, and if I can say the words, osteoblasts, laying down bone, versus osteoclasts.
Yeah. And our goal actually is to almost take it out of homeostasis. So you could argue that osteoporosis is an imbalance where osteoclasts, the cells that break down bone, are doing too much work. Osteoblasts not doing enough work, or they don't have enough raw material, which we'll talk about too. I like to push it the other way. So we like to say in our practice that we can reverse osteoporosis in the vast majority of our patients naturally without drugs, simply by manipulating lifestyle, nutrition, exercise inputs, including hormones, supplements, whatever. But all we have to do is give those cells the things that they need, including the signal to build bone, and we can imbalance it the other way, which is to build more than you break down.
You are preaching to the choir. You're talking lifestyle. So interesting. So really, what causes the problem? Because the bones that are most often affected are the hips, the spine, and the wrists.
Yeah, I look at it more like it's a full body problem. We talk about fragility fractures as being spine, hips, pelvis, wrists sometimes, upper arm sometimes. But really, it's a full body problem. We just don't fracture the other bones because they're not in the same mechanical disadvantage position. So what can cause it? It can be a lot of things. The list is very, very long. Some very common ones, though, I think is poor diet, is the lack of impact, lack of activity, lack of exercise. And really, I'm saying mostly in young adult life, adolescence, early adulthood. This is really when I think we're seeing the biggest errors because we're not achieving peak bone mass by failing to eat the right diet, do the right type of activity, and then we get exposed to all of these potential toxins in our environment. So we are exposed to over-the-counter drugs, prescription drugs, steroids, environmental toxins, heavy metals. All of these things can impact bone metabolism. So it really is a very, very long list, and that's part of what the solution has to be for anyone with a bone problem, figuring out, why am I losing bone? Because I think we do have some accepted bone loss as we age, but it should be very minimal, if any at all. I don't think it's unreasonable to say that we can maintain the bone that we have. That's actually a pretty easy goal to achieve for the vast majority of people.
Fascinating. So to recap, so loss of bone there's medications, poor diet, lifestyle, probably some medical conditions. We're going to get a little as we age, as you said, probably the lack of weight-bearing exercise. Something I'll throw out there, which I'm sure you'll run away with, is the increase in inflammation in the body, which is my mantra to manage and modulate inflammation, and probably some surgical interventions. So with that as a recap, what about this thing called estrogen and a drop of estrogen and its effect?
Oh, yeah. Yeah, hormones are such a big player here. And so when we started creating this program around bone health, we were already doing hormone replacement, but I realized very quickly, like, we have to now become experts in hormone replacement because we're dealing with a population that has, what would a lot of times be considered contraindications by some doctors or reasons to consider not using hormones. But they also have severe osteoporosis. But what we found is that estrogen, specifically estradiol, testosterone, progesterone, even DHEA, some of the other androgens, they all impact bone in different ways. So we realized, man, we really have to work this into our program in whatever way that we can. And so women, of course, most women know this at this point, women will go through menopause if they live long enough, and they will lose the vast majority of their, at least estradiol, maintain a little estrone. But estradiol is the most potent estrogen, and the impact of that is rapid bone loss. And I've heard different numbers around the actual amount of bone mass that you can lose during the first 5 to 10 years after menopause. Some people say it's 10%. Some people say 30%. I've heard up to 50%, which seems really high. But whatever the number is, it's high. And so then the question is what's your starting point before menopause? What's happening in perimenopause? And this really should be a part of the conversation of, should hormone replacement therapy be considered for you, knowing what your starting point for bone is, and then in conjunction with all the other things with healthspan. So absolutely, estrogen is a huge player here.
Well, you brought up 2 points of note, without question. Healthspan, part of the longevity conversation, the incisive conversation of 2023, 24, and possibly 2025. We both said that we'll be at A4M, which is the leader in anti-aging. So my question is, bone health, healthspan, and you brought up HRT. So my wife, 52, going through the proverbial changes. What about HRT for her? What about HRT for bone health?
Yeah. So I think every woman should know her starting point before she goes through menopause. So we'll put a pin in screening and talk about that in a little bit. But there is that predictable loss of bone mass. If you know your starting point and it's really high, let's say you have abnormally dense and strong bone, then if you have a compelling reason not to use HRT, then I would just potentially watch it for bone health. But that's not most people's starting point. I think arguably most people already have osteopenia, which is the kind of transition phase between normal bone and osteoporosis, for especially women in their early 50s. It's what we just see across the board. So if that's the case, then it is a compelling reason to consider HRT, in addition to all the other reasons to consider HRT. But it's a compelling reason to use especially estrogen and progesterone, because both of them are going to have an impact on bone health.
So basically, I want to ask you this. How can individuals identify the key contributing factors to their bone loss? What do they need to do?
Yeah, so we like to use this framework. We call it the 4R framework. And the first R is just to recognize why you're losing bone. Because like I said, a little bit of bone loss is either acceptable or maybe expected. I argue that we don't have to. But really, if you're rapidly losing bone, you're losing 1, 2, more than that % per year, there is something wrong. There is something wrong under the hood, and you need to lift up the hood and look underneath and see what's going on. So we do that, though, through a bunch of different pathways. Sometimes it's simply asking questions, like for your wife, for example. Hey, I went through menopause, I didn't start HRT, and I see that I lost 3% of my bone mineral density last year. Well, yeah, your loss of estrogen could definitely be a part of that. But a lot of times we'll use biomarkers, we use blood tests, extensive panels in all of our patients, we use functional testing. You can really go down some deep rabbit holes to look for causes, but usually there is something on the surface that we can work with.
So I'm going to press that issue a little bit.
Yeah.
What blood tests, what DEXA scans, what functional tests would you recommend? Because you just definitely stimulated my curiosity. I'm curious.
Yeah. So let's start with imaging. So DEXA, like you said, is what everybody's heard of. It's what everybody knows. It's what's covered by Medicare once you hit 65, which is way too late, by the way. So the DEXA is basically an X-ray. It's just a flat table. You lay on it. The wand moves over your body, and they give you some numbers. Those numbers are your bone mineral density, and they deliver it in a T-score, which is a statistical analysis of your bone mineral density compared to that of a sex and ethnicity matched person with a peak bone density, in theory, in late 20s. So that's the T-score. And then osteopenia is a particular range. Osteoporosis is a particular range. That's fine. It delivers some information that we can use. But DEXA is flawed because it only tells us about bone density. It doesn't tell us about bone quality. Fracture risk is a combination of those two things. So we're missing a big piece of that equation. So there is another modality that is gaining popularity, not yet covered by insurance in the United States, but is getting hopefully accepted soon into some of the other health systems in the world, particularly the NHS in the UK, I think has taken a keen interest in this. But it's an ultrasound device that comes from a company out of Italy called Echolite. Echolite has a device called a REMS. REMS is an ultrasound that looks at bone, and it'll tell you about both your T-score and bone density, but also has a fragility score telling you about bone quality, which really helps to make some decision-making around how aggressive we need to be with the treatment of osteoporosis. So I would encourage people to find a REMS if they have access to it, and that's the problem because there just aren't as many.
My 45 to 50-year-old female patient goes to her primary care physician, her OBGYN. Rapid fire now. This is fun, New York style. They want to order some blood labs for osteoporosis.
Yeah.
Yay, nay, calcium.
Serum calcium doesn't tell me anything.
Vitamin D.
25-hydroxy, yes, it's important. Most people aren't actually deficient these days, but I also want to know 125. I want to know calcitriol.
Parathyroid hormone.
Absolutely. Got to know it.
Osteocalcin.
It's okay. It's not on our panel. It tells you something, but we can work around it.
ALP.
Tells us something. We have it as part of our panel. It's not my favorite.
UNTX.
So UNTX I would avoid because that's an older marker. CTX is the new marker through blood that tells you the same thing, function of osteoclast. And yes, that is a gold star. Highlight that one.
Muscle mass. Not a blood test, sorry.
Yeah, I mean, muscle mass is important, so they would be getting a DEXA probably anyway, and if they could give us some muscle mass metrics to go off of, that would be great.
Inflammatory markers like elevated like ANA, HSCRP, etc.
Yeah, we always look at CRP. I'd love to have a more comprehensive panel, but CRP is cheap, easy, and gives us what we need.
Well, I just bought a blood lab. Haha, just a joke. I just bought a serum lab. And I want you to design a blood lab panel for osteoporosis for women. Obviously, I'm then going to ask you for men.
Yeah.
The floor is yours, my friend.
Well, I'd have to pull up my list to know everything that's on it. But I think the big things, you got to know what you mentioned, NTX. So CTX is the serum marker that I love. That's the breakdown marker. P1 and P is the buildup marker that goes along with it. So those two bone turnover markers we use intermittently throughout our 12-month program to make sure that we're headed in the right direction. And they're awesome because imaging takes time. It could take 12, 18 months to see changes on imaging, sometimes 6, but usually longer. So those bone turnover markers are awesome. So definitely need those. We need to know hormones. And we don't need to just know like a little bit about hormones. We need to know a lot about hormones. So regardless, male, female, we need to know estradiol, total testosterone, free testosterone. I want to know your DHEA levels. I want to see if we can measure progesterone in you cycling or not cycling and on replacement, either way. I want to know all those things about your hormones. I do want to know about inflammatory markers like you mentioned. I also want to get some basic stuff just to make sure we're not missing anything. You know, let's get that complete metabolic panel. Let's get some cardiovascular risk factors. It's a big perspective because when we talk about nutrition, you'll see that we encourage people to consume more protein, more dietary fat that can have an impact on cardiovascular risk. And we always talk about cholesterol. So we need to go down that rabbit hole. And that's going to include, of course, the lipid panel, but then it's also going to include the more advanced markers, your ApoB, your LP(a). We want to know about homocysteine. We want to know about your omega-3 to 6 ratio. All of these different things we can do, right? What am I missing here? Gut health is functional. We talk about that later. I'm sure I'm missing others, but those are all the ones off the top of my head.
I'm sure everybody had pen to paper on all that. So I'll just
it's on our website.
Share your website with everybody. We'll have them in the show notes, but share your website.
Yeah, so I hope it's still there. But optimalhumanhealth.com is the website, and the program is the Optimal Bone Health Program. It's the only thing we talk about there.
It has been stated that women lose a lot of bone before they reach the age of 40. However, men lose more bone after 40, which really begs the question, if that is true, when should a woman start worrying about osteoporosis? Now.
So I think I would like to see everybody get a REMS in their 20s. You should know what your peak bone mass is, right? Let's know what your starting point is. Because imagine if you knew if you knew as a woman that you had osteopenia and you were 28 years old, would that change the way that you train your programming if you are considering running a marathon versus doing resistance training versus adding some impact in versus, hey, I'm thinking about going vegan for whatever reason, or maybe I should really be focusing on protein. It would change so many decisions if you knew that that was a risk factor out of the gate. So I think you should know in your early adulthood.
Great question. Get ready. Here it
Got it.
comes. What diet is best to avoid osteoporosis? The diet wars. Here we go.
Here we go. Yeah, so I don't shy away from this. I say it very proudly because the literature is very, very clear. You have to consume adequate protein. And the question follow-up is, well, how much? So we say 1 gram per pound because we're in the US and people use pounds. The literature would suggest that there's a threshold around 1.6 grams per kilogram, but that is of, highly absorbed quality protein measured and delivered. So I think we need to round up to 1 gram per pound or 2.2 grams per kilogram, and preferably from animal sources. The reason why I say that is that the amino acid profile fits, they're going to be absorbed better. And actually was just writing a script for a paper demonstrating the impact of the anti-nutrients, phytic acid, oxalates, et cetera, on the absorbability of amino acids through plant proteins. And it knocks it down even more than the amino acid deficit. And so that is the foundational thing. It has to be a protein-forward diet from good sources. And the literature to support that, again, is robust. You'll see it in, just the amount of protein people are consuming, but then also the sources. Animal protein, more protective of fracture. Plant protein, less protective, in fact, increasing the risk of fracture. If we look at cohorts of people who are vegetarian and vegan, higher risk of bone mineral density loss and of fracture over and over and over again. So I don't shy away from this, and people don't generally give me much feedback either negatively because I'm just presenting studies. So that's the foundation, is it's a protein-forward diet. Additional things is it has to have adequate calories. We see this in our population abundantly where people are just under eating. So we have to look at how much food are you consuming? Do you have adequate just nutrition in general? So we have all of our patients track if they're willing to do it. And we make sure they're getting adequate calories. And then you can start adding in the other things. Okay, let's talk about micronutrients. Yes, vegetables have micronutrients. You have to be prepared the right way. Fruit has micronutrients. Fiber has benefit, variable person to person. And then once you sort of do that and you get those things in, then you can start talking about the things that you really like. So if you want to talk about, but I really like grains. What grains can I eat? Okay, here's some examples. What about beans? I love lentils. I want to eat seeds. Okay, let's talk about the things that are going to be beneficial and not negative. We can work our way through all of that. But if you just take a simple picture, which is protein forward, adequate protein, 1 gram per pound, adequate calories, that's going to fix the majority of the people with osteoporosis' nutrition problem right there.
I love it. I'm a big proponent of protein, animal protein especially. I wholeheartedly agree with your ratios. In addition to that, it's a great conversation about the phytonutrients. Not that I differ with you, but I think clarity now. When you say people aren't eating enough, I think you mean that they're not eating enough nutrient-rich foods as opposed to eating enough calories.
Yeah. So general population, I totally agree with you. In our osteoporosis patient population, though, they generally are just not eating enough calories. A lot of times they actually do eat a pretty good diet, but our patient population is very unique. We talk about this all the time, where we have underweight patients, not overweight patients. We have patients who are so dialed in on their diet that they're overdoing it and they're just looking at the wrong goals. And so we're just unique in that way. But I agree with you. Usually people are eating calorie-dense, nutrient-poor food. That's just not our patient population in general.
Now, do you take a patient history in addition to a diet history and you mix it? So I'm coming in.
Yeah.
I'm going to send my wife into you.
Okay.
And I know you're going to use a protocol that's going to help to increase bone growth and combat osteoporosis. What is her encounter with you like?
So we only enroll people in a 12-month program at this point. We were toying with some ideas on how to shorten that, but we like that time because it takes time to build bone. It takes time to change lifestyle habits. It takes time to change diet to see impact. So we know that we've got you for 12 months. So when you come in, we have you fill out a pretty extensive questionnaire, and then we get the biomarkers that we talked about. You meet with one of our functional dietitians who is just robustly trained in gut health, and they do an initial intake, make some initial recommendations. You start working on that. You get introduced to all of the resources that we have, our Osteo Collective community, which is both patients and non-patients, all of the content that we have. So if you have like a specific thing, like I want to watch a video on whatever, we got that video. And then you meet with your provider. So the provider would generally be me or one of my APPs, and then we would go through the biomarkers. We spend an hour talking about lifestyle, biomarkers, customized supplement plan. We will discuss hormone optimization. Depending on the scenario, we'll do replacement. We talk about peptides in there as well, and then we create that plan to move forward. And then you move forward with whatever time is left in that initial 6 months, call it 4.5 months, and then you retest your biomarkers. You meet with the provider again. In the interim, though, you have access to both your dietitian. We have group coaching built in there. We're actually bringing on a trainer right now. We have training in there already, but we want to customize it more. So we're bringing on a trainer right now. So you have access to ask questions. What does this form look like? Should I be doing this exercise? Whatever. So we can hit all of those foundational pillars, retest at 6 months, see how we're doing, adjust, rinse, repeat, and then do it again for the rest of the time that you have with us. That's what that first year looks like. And it is an awesome way to improve bone health.
Outstanding. I've heard great things about your program. I mean, that's how we met through a colleague that we both know, Dr. Carrie Jones, who is without question the queen of hormones.
Yes.
So I'm a gut guy. I believe that the gut is the epicenter of your health.
Yeah.
An unhealthy gut microbiota potentially contributes to the development of osteoporosis by influencing bone metabolism, calcium absorption, and hormone regulation. Quality gut microbes can increase bone mass and improve osteoporosis by inhibiting osteoclast proliferation and differentiation, including apoptosis, reducing bone reabsorption, or promoting osteoblast proliferation. So one, what do you think about that? And two, do you test for gut health?
Absolutely. Yeah. So pretty much all of our patients are getting a stool study. So we use, generally we use GI effects depending on the state laws, but we're going to look at, deep at microbiome, inflammation, do we have any parasites? Do we have any signs of leaky gut and function? So, and I will say that it is generally robustly positive. I mean, there's a lot to work on. And so we actually used to not, it wasn't included in the program early on, but we just realized we're like, man, everybody needs it. So let's just make it a thing. So we're not having to nickel and dime you for it. Let's just add it in. So yeah, we do that for everybody. And we don't hire a dietitian unless they are very well trained in gut health.
Great conversation. Okay, so really begs the question. So you're testing for gut, you're worried about bone differentiation, if you will. What's your nutritional protocol?
So it's all customized, of course, but we have to learn where the starting point is. So we'll have them track initially, and then they'll, take that data and we'll say, okay, you are likely, again, deficient in calories, deficient in protein, and let's look and see what's happening micronutrient-wise. That's kind of hard to track. That's not super accurate, but you can get a sense of where people might be deficient. And then we help them just to create, and we want them to do it. So we don't just give you a meal plan and we're like, follow this meal plan. We help people to redesign their diet over time and take as baby steps as we need to. But it has to fit that person, what they're willing to do, what their family is willing to tolerate. I think there are so many challenges around changing diet because you have to take into account the whole family. When I change my diet in my household, like it impacts my wife, it impacts my kids. And so I need to give that feedback to the person that's telling me to change my diet. So I can't tell you one way that it is protein forward, and we're having everybody hit those metrics we talked about. But outside of that, it's pretty much all customized.
Let's talk supplements. Here we go. We'll do a little rapid fire. I enjoy rapid fire. Where are you from originally? You're doing great on this rapid fire. I usually throw people off.
I'm from the South. I'm from Kentucky, but I've lived all over.
All right. Well, let's go. D3, yay or nay?
Yay, but not as high as most people would push it.
K2.
Yay, as MK7 preferably.
I agree. Indeed, indeed. K1.
Don't supplement it. People are getting it through diet. Not against it. It's not true. It isn't one of our products. So yes, but not intentionally.
Calcium, and if so, what's your favorite form?
Yes, right now we're using AlgaCal, which is an algae-based calcium product,
Mhm.
more so because it's combined with a lot of other stuff that we like. So whole food forms, absolute must. I would stay away from calcium citrate, calcium carbonate. So algae or MCHC forms of calcium.
I agree with that without question. Magnesium.
Absolutely. Probably need more mag than calcium. And then form going to be some kind of chelated form, glycinate, or something else that's going to get absorbed and not cause too much GI distress.
Calcium to magnesium ratio for osteoporosis.
Yeah, this is a toughie. So I would like to say that we're providing our patients 2-to-1 magnesium to calcium. It ends up not being quite that much because I can't manipulate the amount of calcium in the AlgaCal product. If I had my own products, I would have it as a 2-to-1 ratio.
Short chain fatty acids, gold medal winner, of course, being butyrate.
We add it where needed, or we're encouraging diet changes that will provoke it.
Without question, the studies really show that the dietary changes in the production of butyrate are far superior to the oral supplementation. Pre and probiotics, so fiber and the probiotic, if you will.
Yeah, we're talking about fiber mostly through diet. Sometimes we add it based on symptoms. And then probiotics, I don't see our team using them as often as we used to. It used to be everybody. And now I would say it's probably based more off of testing.
You mentioned peptides. I'm excited when I hear that. I use them in my office. I use the oral form. So let's talk about the Swiss Army knife of all peptides, BPC 157.
Yeah.
For osteoporosis.
I've not seen evidence that BPC can directly impact bone health. I think oral BPC, if you're going to go that route, oral BPC is going to obviously improve the gut. It's going to improve gut lining, gut function. So it should indirectly impact osteoporosis. We don't use it a lot because we have some other tools that we use more frequently, but I like it. I wish we could get the injectable form as well. Hopefully that'll come back.
I'm going to segue back to the gut because, like I said, the gut's always on my mind. It's omnipresent. You use a microbiome test. Would you consider a gut barrier panel test? Zonulin, including.
Yeah. I'm familiar. We used to use the Zoomer tests, which gave us more insight into gut barrier. And then there was another company, I can't remember what it was called, that I've used in the past as well. And it gives good information, but I can tell because the GI effects, you can add zonulin. So you get a glimpse of what's happening. But I would say when we used the more comprehensive tests, everybody had leaky gut.
Yeah.
So it didn't really change. It didn't change our protocols, and they're relatively expensive. So we don't add them in now because I think we already know the answer with what we have.
So getting back to the idea of testing, and how would you recommend people, or how often would you recommend people test their bone turnover markers?
Man, if finances weren't an issue, I'd love to see them every 6 weeks. I think it'd be amazing, but they're kind of expensive. So we do it, depends on the case. Some people will do more frequently. Some people would do as infrequent as 6 months if things aren't likely to change quickly. So somewhere in between there, maybe every 3 or 4 months is a sweet spot. But like I said, they're not inexpensive. A lot of doctors are not willing to order them because they don't know how to interpret them. So therefore, you're going to pay cash, and you could be, $600-800.
So how do you know they're getting better? What are these bone indication markers are you looking for to?
Yeah. This is a great topic. So this is something I saw in a paper, I don't know how long ago. When I first started looking at the bone turnover markers, I just intuitively, I want the bone breakdown to go down. I want the bone building to go up. That just makes sense, right? But that's not how they work because our bones are smarter than that. So bone turnover generally is going to go in the same direction. What we want to know is the ratio. So if they go in the same direction, but the building goes up a lot more than the breakdown goes up, then we know that we're headed in the right direction. So we had to come up with a calculation, and I saw it in a paper, and I forget how long ago this was, but they basically used this P1NP over CTX. So that's building over breakdown adjusted for units. And when you do that, you get a 3-digit number somewhere between 100 and, call it 300, which makes a really easy range to look at. So now we're basically looking at this P1NP over CTX ratio, and we're monitoring that over time, and we're learning all of the tools that are going to most significantly impact that ratio, and we're compiling a list of all those things, and we have this, again, just our protocol just continues to get better and better. But that ratio is key.
That's the key takeaway. All right. So everybody write that down. That's the salient point of the conversation to date. I want to talk a little bit about you. I mean, you do a great job. You have the Dr. Doug show behind there. You're articulate. You're helping people. You are a trained orthopedist, Stanford trained, and you spent like over a decade, is my understanding, being a traditional orthopedist. And here you are, on the out. When I say on the outskirts, you're not doing your typical orthopedic training. So I say I'm having Dr. Doug on, Dr. Doug Lucas, and he's the guy who used to fix bones. Now he's the guy who saves bones.
I
How'd
love
you
it.
get there?
Yeah. Well, I was in the traditional medical model, and I quickly realized, because foot and ankle was my subspecialty. I did general call, I fixed hip fractures and saw lots of fractures, but foot and ankle was my subspecialty. And foot and ankle is probably the subspecialty with the least impact for the amount of effort from a surgical perspective, meaning that I made a lot of people different. I didn't make a lot of people better, because we were fighting an uphill battle of metabolic disease, neuropathy, challenges that were not going to improve significantly with surgery, and just doing the surgery that we had to do in order to keep people, mobile. So that was frustrating. I also, sort of at the same time as I was training for orthopedics, my wife was getting her PhD in nutrition. And so she launched a business, same time I went into practice. So I started seeing her having this tremendous impact in people's lives simply through nutrition. And it really got me thinking about my patients, because they needed that information. And so, I was learning myself about my own nutrition and my own lifestyle and training and what this all meant. I started passing that along to my patients and met a lot of resistance. Not actually just from my patients, but also from administrators. I had an insurance company once tell me, my own malpractice company tell me, that I shouldn't be talking about nutrition to my patients. They said, I'm not trained in it. So just feedback over and over again that perhaps I'm in the wrong place. But it's really hard to leave a surgical subspecialty, because it is a high-paying W-2 job, and I got a mortgage payment and 3 kids, and I got all the things. So we reached a point where I really wanted to have a different lifestyle. There's a lot of, around here in Asheville, there's you have to take trauma call. There's no way around it. So the lifestyle is very challenging for the orthopedic surgeons that work here. And I needed to make a change for my family. It was some things that were going on in the family, and I really wanted to be able to treat patients differently. So through some challenging conversations around how we're going to continue to pay the mortgage, I went part-time and drove 2 hours to go to work, and then did the fellowship through A4M, and sat for the board certification, additional hormone training, epigenetic training, and then launched the company. And then very quickly found my way into osteoporosis. So it was kind of a weaving path into what is now, the Optimal Bone Health program within Optimal Human Health. And we've built an amazing team around it. So very happy to be here, but it's been now 4.5 years since I made that leap. And it's been a challenging time.
Wow. What a great track. Interesting. So share some case studies and examples of how you reversed osteoporosis at Optimum Human Health. Everybody loves the case study. Everybody wants a human study. Give me a story.
Yeah, so I was actually just prepping a talk, and I was pulling in some of my favorites. So I look at this. There's kind of like 3 groups of people. So the one that I actually just pulled in is it's actually a guy. And this happens in women too. So for all the women who are mad that I'm talking about a man. But what I like about this guy is he was 62, recently retired attorney, got a DEXA, I think for body comp reasons, and realized he had osteoporosis. And it just blew him away, because he's a go-getter, high functioning, kind of felt like he was taking good care of his body kind of guy. And so his program was very simple. And that's what I love about this story. His program was very simple. It was gut health. It was nutrition. It was changing the way that he was he was already exercising. He wasn't, a couch potato. He was already doing it. He was just doing not all the correct things. So he changed that. All of the foundational stuff. We didn't go on testosterone. He didn't need hormone replacement. He did, but he didn't want to do it out of the gate. And what was really compelling here is that he demanded that he get every 6 months a new REMS. So he would drive from Ohio down here to Black Mountain, North Carolina, which is like a 10-hour drive or something. And he would get this test done every 6 months. And so we now have, I think we're going to get 2-year data soon. But at 6 months, he was already seeing improvement on REMS, which is great because 6 months is really early to see improvement in imaging. So he went from osteoporosis actually even into osteopenia, but just barely. So it was like a, like a 6% change, which is actually a lot for bone. But with this story, not a lot. So then we made a few adjustments, and then he went for the next 6 months, repeat it at the 12-month mark. And I think at that point, he was now at like 10% in his spine and something like, like, I don't know, 12 or 14 in his hips or something like that, like really robust changes for 1 year. And then he gets an 18-month scan. At the 18-month scan, he was over a 25% increase in bone mineral density, which is just unheard of, right? Now, at the 12-month mark, we actually did start testosterone for this guy because it just continued to drop and drop. I think he was training too hard, but he needed it in the beginning anyway. So he did go on testosterone at that point. I think that's what really drove that spike up to the 24, 25% mark. Mm-hmm. So it just goes to show he wasn't on peptides. There's nothing fancy. He just did the things and his body just responded. So that's like one group. We have several guys that are in that group with this crazy response. And then we have our kind of like your wife. So just either right at menopause, shortly after menopause, early 50s, deciding yay, nay, hormone replacement therapy, get diagnosed early. And similarly, they are not in usually as bad of a place as the third group I'll talk about. They might have pretty significant osteoporosis, but they're very active. They're willing to do all the things, change the diet. They can go on HRT with actually, no risk because it's actually protective of risk. And so that's a really fun population because it's also, again, really easy. And so one of our favorite early patients, she is now 2 years out and she just had a repeat DEXA. And so I think she was like over 20% in her spine and something like 15% in her hips. And what was really cool about her is that at the 12-month mark, her hips got better, but her spine got worse. Mm. And so this is one of those examples where we're like, like, what did we miss here? Because clearly if her hips got substantially better, she had all the things. So why did her spine get worse? And so then we started digging into the exercise side and she's like, oh, well, I have this thing in my back. So I don't load my back when I'm doing the exercises. And I'm like, but like you have to load your spine, And so we fixed that and then her spine got better. She just needed to learn how to do it. So that's another really good example. Now, the third group is our women that are, mid upper 60s, early 70s. This is the generation of women that were totally screwed over by the Women's Health Initiative. There was no conversation around hormones. And these women never went back on it. There was never any conversation about it. And so they've been estrogen deficient on top of all the other things. And so then we have to have challenging conversations. Okay, so you're 20 years out. Is it safe to start hormone replacement therapy? What does your cardiovascular disease look like? All these things. So some of them can start hormones, some of them can't. But both of those subgroups within this age group, they can both get better. The women on hormones get better faster. But what I love seeing is the women that are not good candidates for HRT, they still get better. It's just slower. And that's okay because they hopefully have a long time to do it. So those are the kind of three different scenarios that we see people coming into the program with. And it's so fun to see them improve the different ways that they improve.
That's great. And great examples. And I'm happy you used the male as an example because that was going to be my follow-up question. You stole my thunder. Not a problem. But I always like to end, because I know time is limited, I always like to end with 3 key takeaways. So if someone listens to this podcast and they say, okay, I want 3 tangible, implementable things to do on Monday morning, what would they be, Dr. Doug Lucas?
Yeah, so I would say number 1, which we'll cover the next 2 as well, but number 1 is be an advocate for your health. If you think that you need something, you have to remember that you are the customer in your doctor's office. Demand what you want. They'll give you their advice, and that's fine. But demand what you want, because if you have a need, your body has a need, you're the only one that knows it. So number 1 is be an advocate for yourself. Number 2 is hormone replacement therapy. So there was just a publication that came out from the Menopause Society that said that 4% of women over the age of 50 are on HRT. So for the other 96% of you, please consider having a conversation about the risks and benefits of hormone replacement therapy with a doctor who understands that if you have osteoporosis, you have a compelling reason to use HRT, even though some of it's off-label. But you have a compelling reason to use HRT because it is probably the biggest tool, hands down, to improve bone health, bigger than the bone health drugs. So HRT, you have to have that conversation with the right person. And then number 3, I would say, is diet. no matter what your health span goals are, if it's bone health, if it's brain health, if it's heart health, we need to eat a protein forward diet that is going to optimize our muscle mass, optimize our bones, optimize our gut. We have to be very conscious about this, because in our culture, in our society, terrible food is around us all the time. So we have to be very conscious about what we're eating. You have to make sure that everything you put in your body has a purpose.
Outstanding. So you gave him the 3 takeaways. I appreciate all that you do. I look forward to seeing you next week. Everybody, we are Proven Health Alternatives. Osteoporosis specialist, guru, Dr. Doug Lucas. Thank you very much for your time.